All right, everyone, ready for sign-in? Let's introduce the team. Dr. Tube and Dr. Regional from anesthesia. Dr. Drill, orthopedic surgeon. Name and duration of procedure.
The surgery is ORIF, right-sided humerus and elbow fractures. The expected duration is 5 hours. Regarding the position, first it will be supine, then I will need to change it to a lateral position in the middle of the procedure.
Proposed anesthesia.
Regional.
GA.
Dr. Tube, I've got this all figured out. Regional anesthesia. It's like a walk in the park. No tubes, no drama. Just a little needle and a whole lot of relaxation, I tell you. With the ultrasound, we can precisely guide the nerve block. But don't worry, if we ever need to intubate the patient, then with my brilliant ultrasound skills, I can assess airway, to predict difficult intubation, to do gastric ultrasound, to detect full stomach, diagnose bronchial, or even worse, esophageal intubation. And I can also mark cricothyroid membrane to do phono if things go downhill. So, with my mix of skills, I think it would be much safer to do regional block in this patient.
A walk in the park? More like a walk in the minefield. What happens when the nerve block decides to go on vacation, leaving the patient feeling like a balloon without a string? Can't you see? This is facial trauma, and a closed mouth intubation could be extremely difficult. Maybe he already sustained brachial plexus injury, and maybe he will during the surgery. In cases like this, where airway management is critical, general anesthesia gives us more control right from the start. We can ensure the airway is secure without running into the risk of unanticipated failure.
But general anesthesia does not come without a risk. And with regional anesthesia, we avoid those risks. Plus, why cross the bridge before coming to it? Listen, I'll give you a deal. If we ever needed to cross the bridge and intubate the patient, I can topicalize the airway for you using spray as you go and well-executed upper airway blocks. And if we need to intubate in a rush way, I can sneak in some IV lidocaine to reduce the cough, reflex, and stress response. I mean, come on. I do not know why you're so skeptic. I have got my trusty ultrasound to guide me. It's like having GPS.
A GPS that occasionally leads you to a dead end. Not on my watch. I mean, you're assuming everything will go smoothly. Have you ever heard of Murphy's Law? Listen, my friend, why don't we just assume that this patient is like many other patients where we don't have the luxury of waiting for your regional anesthesia to work? Just crack on with intubation and general anesthesia, and everyone can go home. Believe me, you don't want to upset Mr. Surgeon. If this patient develops a compartment syndrome and that goes undetected because of your block, then both of our heads are on the line.
Well, let us agree on something. Surgeons are never happy. But guess who else is not going to be happy if you can't intubate and can't ventilate after trying to manipulate this patient's airway? The legal team. You will be on your own if this happens, my friend. Please listen, regional anesthesia will potentially prevent this scenario. Plus, I'm a woman of a science, and most of the evidence for late diagnosis of compartment syndrome after nerve blocks come from low level of evidence. Those case reports.
Science, huh? Well, let's see how scientific your regional block is when the patient starts gasping for air. The problem is you're underestimating the potential for complications. What if the nerve block affects the airway, like with a recurrent laryngeal nerve block? Or if there's a pneumothorax from your supraclavicular block? I hate regional anesthesia. I still get flashbacks from that patient I was called to intubate because he was a difficult airway. He stopped breathing and became unconscious just because of a total spinal. If the complication arises when we would have no choice but to intubate immediately and in a patient with a facial trauma, closed mouth, that's going to be a nightmare.
Come on, this is taking too much time. Shall we proceed now, please?
Okay, Dr. Drill, please give us 2 minutes. We will finish our discussion and come back to you. Dr. Tube, those complications are rare, especially with ultrasound guidance. And using regional anesthesia avoids the need for intubation altogether, which reduces the overall risk in this difficult airway patient and potentially avoiding a catastrophic situation. I mean, just think about it. If this surgery gets done under the block, then patient will feel no pain whatsoever even after the surgery, which is like a magic.
A magic that could end in disaster. Plus, certain patients don't like that sort of magic. In a child, a delirious patient, your block will neither be feasible nor safe. Not to mention the subtle ways that a semi-obstructed airway with rising CO2 and acidosis effect from the pharmacokinetics of local anesthesia, increasing the risk of local anesthetic systemic toxicity. Oh no, I completely forgot about last. That's it. I'm sticking with general anesthesia. It's tried and true, and I'm not the one to mess with a classic.
I understand the concern, but in this patient's case, regional anesthesia seems to offer the best balance of safety and efficacy. With all the equipment and expertise we have here, I believe this is the right choice.
Well, I don't trust your ultrasound machine. I trust my anesthetic machine. General anesthesia is safer in this situation. It allows us to control the airway from the beginning, which is crucial in a patient with these specific complications. We have videoscopes, fibroscopes, and the difficult airway trolley ready. We can secure the airway without delay and manage any complications that arise with a clear plan in place.
We are both trying to do what's best for the patient, but it seems we have different views on how to achieve that. Perhaps we should involve the rest of the team and make a decision together, considering all factors at play.
Agreed. A multidisciplinary team discussion will help us make the most informed decision for this patient's safety.
For any question, please visit our website, www.damsociety.com.